that is the optimization of 5-ASA in clinical practice, which is clinically very important. And the chairpersons for this session are Dr. Ajay Kumar, Chairman and Head of the Department of Gastroenterology and Hepatology, BLK, Super Specialty Hospital, New Delhi. Dr. K.K. Prasad, Professor in the Department of Gastroenterology, PGI IBD, Chandigarh. Dr. Nadeem Parvez, Consultant in the Department of Gastroenterology, Neotia Getwell Healthcare Center, Siliguri. Over to you, chairpersons.
Thank you very much. I'm Ajay Kumar. Thanks, Dr. Vishal, Dr. Usha, and Dr. Kocher for organizing a wonderful meeting. We know that we are running short of time, so I'll straightway go to introducing the speaker and the topic. Well, good thing is the speaker is one who doesn't require any introduction. Naresh, of course, is a dear friend and is Chief of Gastroenterology and Hepatology Tester, CMI, Bangalore. I think the entire country, group of gastroenterologists, they know him by his gray hair, and which he's been having for the last 40 years. It doesn't show his age. Well, Naresh, the topic that you are talking, optimizing 5-ASA in clinical practice, you know, in the era when you're talking about immunosuppressants, biologicals, FMT, and FMT talk came actually before the 5-ASAs. So do we have still to learn more about 5-ASA? I strongly believe yes, because the way we are treating our mild to moderate UC, we are treating them with too many medications with an inadequate response to 5-ASA. And I'm sure Naresh in the next 15 minutes will be able to enlighten us on that. Over to Naresh.
Thank you, Ajay. And thank you, Vishal, Rakesh, and Usha for again having me here with you all. Yes, 5-ASAs have been around for a long time, several decades, but unfortunately, the number of studies haven't been very many, and a lot of studies have not been of great quality for us to practice always evidence-based medicine. If you look at the clinical classification of ulcerative colitis, if you look at the old classifications, they had something called mild UC, and they had something called severe UC, and we had moderate was loosely defined as something in between. Attempts have been made over the last couple of years to try and define this more realistically. And this is one of the classifications that I would draw your attention to, which came out in the American Journal of Gastroenterology. And it defines what is a remission, what is mild, what is moderate, and what is fulminant. And what they have done is not only use the clinical criteria and some of the labs that we are used to, but they have tried to incorporate fecal calprotectin and the endoscopic scores into this to be able to make a more accurate assessment as to what kind of disease we are dealing with. The next issue is, of course, how much of the colon is involved in ulcerative colitis, whether it's just restricted to the rectum and the sigmoid, or is left-sided, or extends to the more proximal part of the colon. Why is this important? Is because we have several formulations of 5-ASA. The oral ones, which can deliver it to part of the terminal ileum and a large part of the colon. The enemas, which may go right up to this splenic flexure, and you have the suppositories and the foams, which restrict the delivery to the rectum and part of the sigmoid. Now, this is of great importance, is because the delivery system and where it is delivered makes a big deal of difference. And this is a slide that I borrowed from Simon Travis, where it clearly shows that the amount of mucosal 5-ASA that we can reach is inversely proportional to the histological and endoscopic activity. That means more the ASA, lesser the activity of the disease that we see. And hence, it's important to achieve that minimum amount of ASA to be able to control the inflammation. So looking at the 4 indications, I'll quickly go through these. If you look at proctitis, you clearly see in this chart that suppositories are far superior to tablets, whether it's at 2 weeks or 4 weeks. So it's an absolute no-brainer that in a patient with proctitis, we need to go with the suppositories, and that dosage should be 1 gram at least. There's no great advantage of going beyond 1 gram, but less than 1 gram may have suboptimal benefit. In fact, if you looked at step 1, as I said, is rectal 5-ASA. In step 2, you combine it with a steroid. And this is important, that 5-ASA is superior to rectal steroids, unlike what we were brought up with a few decades ago. Step 3, you add a oral 5-ASA, and in step 4, they are still refractory, then you can add an oral steroid. And once you achieve a remission, you use the same thing, use a rectal, oral, or combined 5-ASA at a minimum dose, and that dose can be 1 gram a day, maybe even daily or even alternate days, just enough to maintain a remission. A lot of patients don't like topical therapy, and of course they would hate it if there are severe flares, that are unable to retain the enemas, and perhaps more importantly, if they're already doing well on oral therapy and they're doing well, they'd avoid topicals. Fair enough, I think that's all right. As long as they're doing well, that's quite all right. But there are certain situations where we must add a topical therapy. If you have patients who are difficult to treat, for some reason they're not doing well on their oral therapy, you must add a topical therapy. And if they have troublesome frequency or tenesmus, I think adding a topical therapy makes a great deal of difference. We now come to mild ulcerative colitis, and we know how it is defined. I won't go through this. But if you look at the various 5 ASAs for remission, inducing remission in mild ulcerative colitis, they certainly 5 ASAs do far better than placebo, no doubt about it. 5 ASA versus sulfasalazine, not much better. There's no difference. Between the various kind of 5 ASAs, depending on the, where they deliver, the pH and the bonding and so on, none are better than the others. So if one doesn't work, there's no point in substituting the other one. The most important thing is the dose. Any dose less than 2 grams is not good enough, and your dosing should be 2 grams or more. And finally, once a day dosing is as good as multiple dosings, and one must leave it to the patient to decide. There are some patients who would like to improve their compliance by taking once a day. The other patients say, I don't want to take such a strong dose at once. I'd like to split it. I think that's fairly acceptable. Now, in mild UC, how do we induce a remission? And what we use is at least 2 grams of IASA. And if you look at week 6, whether you use 2 grams or 2.4 grams of alcohol or the higher dose, there's not much of a difference.
I'm ready.
Now, if you look at a combo, you find that there is a combo is better than solo therapy.
Hello?
I can hear something in the background. Can someone mute their mic, please? If you look at this slide, it clearly shows you that when you use a combination of oral and topical, the results, as you see in red, are far superior than to using solo therapy with oral 5-ASA or mesalamine enemas. So the combo therapy is definitely much better. But remember, when we use a combo therapy, we are increasing costs, and that may be an issue in patients in India. The other thing is that this study clearly showed out is when should we assess response in patients of ASA, and you see that clinical symptoms actually come down by the end of week 3. So do not take a decision before week 3 to decide whether something is working or not. You must give it enough time. So this, as I said, one daily or multiple daily dosing, I've discussed this and shows that there's actually no big difference. Now, coming to maintenance of remission, we know that remission is important. And this shows us that a study, it clearly showed that if you use lower maintenance level dosages compared to what we use for induction, suppose you used 4 grams for induction and here you use lower dose, you find that the results are not so good compared to if you use the same dose as we use for induction. Unfortunately, the levels for evidence for this is not very strong and is largely recommended by experienced IBD specialists who believe that the higher the dose that we are used, and continue the same dose to maintain a remission. Now, this is a more interesting and a vexing topic, and I think a lot of errors are made in this area. As I said, now moderate colitis has been defined, as that in-between area, more than 5 bowel movements with moderate rectal bleeding, some constitutional symptoms, high inflammatory scores, and you can use the Mayo Clinical score or even the endoscopic scores. Now, experts believe that moderate UC actually is to be considered as in 2 subgroups. One is the one which has got an aggressive phenotype. And I've listed out the conditions here that are young patients, males, extensive disease with deep ulcers, multiple relapses and previous exhibition of steroids. These are the aggressive. And the others are perhaps the non-aggressive. And these behave like mild ulcerative colitis overall. And this flowchart or pathway shows us how this is very important. If you have mildly active UC, you've given him your standard dose for ASA, is not better, or he's got some predatory aggressive disease, you certainly don't need to go into high dose for ASA with or without topical therapy. And once you achieve a remission, you continue this. However, if you have moderately active UC with predictors of aggressive disease, then you need to go into a different pathway. And that involves, you don't waste your time using 5-ASA to induce a remission because it does not achieve a remission. What you need to do is straight away go on to steroids. And this I find is, there's a lot of reluctance on clinicians to use steroids early in the game because they feel for some reason that you're worsening the prognosis. Actually, sitting on these patients for a long time is not a good idea. On the other hand, if it's moderate but they don't have these predictors, you can treat them with a higher dose of ISA than the standard mild UC. This, I think, is a very important chart, and I think you should use it in your day-to-day practice, because once you give steroids, then again, your remission is maintained with thiopurines and biologics or whatever. The dosage of ISA in moderate UC has to be a higher dose. A good study which shows that there's a significant difference. And not only that, there's a shorter time needed for resolution and symptom control. So just to summarize, who needs a higher dose of ISA? High oral dose or a combo? It is when you're inducing, if it's a mild UC who's not responding to your 2 grams per day. If he's got moderate UC and no aggressive features, he just needs a higher dose of 5-ASA. In maintenance, again, if the mild symptoms keep on persisting, then perhaps you can add on, increase the dose of your oral or add on and enema of ASA. Coming to the last two issues, one is Crohn's disease and 5-ASA. Again, a lot of mistakes here. We do know that initially Crohn's is a mucosal disease, and over the years it becomes transmural. We also know that about 20% of Crohn's disease may not progress and may remain mucosal disease. And so if you look at the guidelines, they very clearly tell us that oral 5-ASA does not induce remission in moderate to severe Crohn's disease. So absolutely no use to induce remission. However, if it is limited to the left side of the colon, so if you have a Crohn's colitis, which is not very severe, it's mild, you can think of using a 5-ASA. And therefore, for induction of remission in mild colonic Crohn's disease, you can consider 5-ASA or a sulfasalazine. They are not indicated for ileal, ileocolonic, or proximal small bowel disease, but they may have some role in the treatment of postoperative Crohn's for prophylaxis following ileal resections. Now, is there a role for 5-ASA when you're giving the patient a biologic? You're giving him thiopurines, you're giving him curcumin or something like that, or he's got acute severe colitis and he's on IV steroids? I think there is really no evidence that it actually makes a difference. However, it remains a debatable issue. Some clinicians do use it, but I think the basis for that is not very strong. We have always spoken about the benefit of 5-ASA for chemo prevention of colorectal cancer, but the evidence is thin, and perhaps except the patients with primary sclerosing cholangitis, maybe that may be the only group where one may want to use it. Of course, the bottom line is that you must have good disease control. That's most important. So the benefit of routinely continuing 5-ASA in these situations is not proven. Last point is patients with ulcerative colitis who are non-adherent are likely to not remain in remission and have relapses. So it is important to emphasize that patients must adhere to therapy, and for the patient, it is a choice, but from the physician's perspective, that's an expectation for the patient that if he wants to do well, he has to be adherent to therapy. So friends, if we want to make progress, we need to change. And if we want to change the outcomes of our patients, the change has to start in us, because we physicians are also very reluctant to change. And the simple message at the end of this talk is incorporate all the changes and the developments that are occurring around us. All the good talks that you've heard before this and after this will all need to be introspected into and see what you're doing or what you're doing right and what you're not doing right. Make those changes and make your patients' outcomes much better. Thank you.
Thanks, Naresh. I'm not sure whether I'm being audible or my other co-chairpersons are there.
So you are audible, sir?
Yeah, I can hear you.
Okay, Naresh, thanks for sticking to the time and giving a clear messages. And I have, before I ask other co-chairpersons to take over, I have one or two issues. One is that you said that there's no evidence to show that the long-term 5-ASA, along with immunosuppressants or steroids or biologicals, is useful or not. But I like to know what are the current guidelines for that, because I know it's a debatable issue whether they are chemoprotective or not for the carcinoma. But what are the current guidelines?
As I said, it's guidelines say that perhaps you should continue, but the evidence for it is thin. I mean, it is a conditional kind of recommendation. It's not that you have to. Even if you stop it, I don't think it makes a difference. In India, where we're already adding to costs, I think it may be an issue that we could sit and debate. As I said, it's being debated, but there's no conclusive.
Another practical question. Patient with mild ulcerative colitis, we start 5 ASA at a dose of say 2.4. Now my question is, how long will you wait before adding steroids? How long does it take to have that?
3 weeks.
Okay, Sandeep, you like to? I can see Sandeep on the. Who else is on the co-chair?
Dr. Nadeem is the other chairperson. Dr. Nadeem, any questions?
Name on the screen.
Nadeem, you have to unmute yourself.
Sir, good afternoon. So my video is not being started.
My video is also not working.
Yeah.
Your name.
It was a very elaborative and nice lecture by Dr. Naresh, and we all know about him. So regarding the preparations, because oral and rectal preparations, so I think for induction, this combination therapy is good in the initial, but for a prolonged remission, how do talk about the rectal preparations in the remission for a limited proctitis disease?
For proctitis, what I use is anywhere from 1 gram at bedtime. And once they are in a remission, I say that use it maybe alternate days, thrice a week or something like that. And sometimes I even stop because patients are not very happy having a suppository because the disease is not bad, it's not troubling, and they always will know if it comes back, so we can really go back to it. But ideally, one would like to keep it in remission, even with the minimum dose possible. You can use even 500 mg at times, but the recommendation is 1 gram daily or at least alternate days.
Who's the other person on the chairpersons? The 3 names. Okay. How much time do we have, Dr. Vishal?
Sir, we are already short of time.
Okay, then I think I might as well say thank you, Naresh, for a very practical, concise, clear messages, and a lot of things get clarified. Of course, we can keep on talking about the different issues involved in that. And thanks the organizers, especially Vishal, Usha, and Rakesh, to give us this opportunity to be here. Thank you very much.
Thank you. Bye-bye.
Thank you so much. Thank you, chairpersons, and thank you, sir, for a very lucid talk. Now we go on